Hello. Hi, this is Kathy Frey here from IMCO, from the International Integrated Maternity Healthcare Organisation. And I do apologise, we're a little bit late to start today, just technical issues, as normal. But look, welcome, and a big hello to Katherine. Say hi. And so look, I know that you guys are, I can see you're just signing on in, so that's wonderful. And please, if you could go into the chat area and let us know whereabouts you are in the world and what your role is as a health professional, or maybe you're a mum expecting a baby. And also just a reminder that down the bottom is the Q&A button. So if you've got any questions for Katherine, please type them in there. We'll absolutely make sure that they're answered. And today Katherine and I are just going to have a general chit chat, and got some points that I know that we want to go over. It's an incredibly important topic that we're going to be covering here today, and you know, it's a delicate topic as well, obviously. But look, just to give a little bit of an introduction to Katherine. So Katherine Hyde Hensley is a psychotherapist and a group support facilitator. She's skilled in personal healing and growth, and works for individuals to find their path. And Katherine is also a licensed clinical mental health counsellor, so a lot of, you know, psychological knowledge in there, and she's also uses what she calls a modern psychoanalytic process, which I'm sure she'll talk about, which combines narrative therapy, resilient grieving, and physiological hope therapy. So the topics that we got, and there's a lot more about her as well, which I'll get her to introduce herself to you on. And our topic, of course, today is, you know, finding our rainbow, which I love that term that you have, Katherine. And you know, when you are a birth practitioner, I think we know that we all generally are in this role because it's such an amazingly joyous, miraculous moment to see a baby be born and be part of that process. But there's another part of the process as well, and that's what is the babies that don't have the great outcomes. So welcome, Katherine, and please you know, expand on that introduction and tell our audience.
Sure. Yeah. I noticed that we had a midwife and a doula joining us, and so that's really where I got my start. Is I gave birth to our third child, and she was stillborn at full term, and it just rocked our world. And so having not had the support I needed in my fourth trimester, I grew a rainbow. And so having lived that walk, I decided it was time to give back and help other women. So I became a certified birth and postpartum doula through Doulas of North America. And then found myself gravitating towards perinatal loss and palliative care. So helping families with unsatisfactory outcomes, parent in the utero, parent in the process of growing a baby. And so that's what led me to become a psychotherapist and really kind of get behind what families needed after a significant loss, and in order to prepare their body, their room, their womb, their life, their family system for sustainability.
And you know, it's that whole process, isn't it, of being the victim, then the survivor, then the warrior. And I find it very interesting that you did your psychoanalytical training after the event. Quite often we have expert specialists here who are had done a particular field of study, but then because of a personal event, it became a focus on maternity, on an aspect of maternity. And you did it the other way around. You had the event and then you went, right, this is not good enough. We need to, you know, I need to find out more as to how I can be of help. And so your entire focus has been from the get-go in this subject practically, which is, and how long ago did the journey begin for you?
So we lost Helen. She was our third 15 years ago. So
gosh, and she was your third. So not that but you would have been so unexpected with that. I think, you know, with your first, you know, you do worry about everything, and you know, with your third, we're just a little, you know, I've dealt with lots of mums having thirds, and they're just delightful because they're usually just so relaxed and they're so chilled out, and you know, they actually enjoy their pregnancy, probably more for the first, you know, physically it's harder, but mentally it's easier. And gosh, rock your world would have just been the biggest understatement ever.
Yeah, it's that cycle of blindsided, and just you know, it wasn't talked about. You know, there was little talk about kick counts. There wasn't any really red flags. So I had 4 babies in 6 years, and it's really kind of the basis for interconception care is to heal heal the uterus.
So you went on and had a 4th baby quite quickly after that one. After Helen. And that, which would have been, I guess, part of your healing process as well. Often we have women, I often get, because we, myself and a Australian obstetrician and some other health professional, maternity health professionals, medical herbalists, pharmacists, etc. And we run a Facebook forum called Ask the Maternity Gurus. And one of the common questions that does come in there is, you know, how long should I wait? And, you know, I've had this loss, how long should I wait? And I don't know if my answer is right or wrong. I don't know that there is a right or wrong, but I always sort of say to women, when you're ready, you're ready. And if you're ovulating, your body's ready, you know? So I think that this idea that people should wait a set amount of time, I can't see the logic in that.
It's can you handle another devastating loss? Because we have some moms who have multiple stillbirths or multiple losses month after month or every 6 months. And so there's only so much the heart and soul can take before you break down. And that's where therapy, hope theory can really play an important part, is helping the couple decide, are we ready? Why are we ready? Can we start practicing again? And
that's the correct focus, because I think that there's this impression, well, not I think, I know there's this impression out there that there is some set magical time, you know, that you must wait 6 months, or you must do this, or you like, it's, I can't understand that, because, you know, surely for a lot of people, the most healing thing for them to be able to do is to start to carry another baby. But anyway, we're getting ahead of ourselves. So I have other things that I want to ask you, but look, it's just so
ask
important.
Away. I'm good.
It's great. So look, how is perinatal loss taking a toll on families? You know, I know that you've probably got some statistics on that.
Yeah, so according to Postpartum Support International, that it's costing $14.2 billion per year at the average.
And that's obviously just in the US.
Yes. Correct.
Yeah.
Well, that may be international. I really should know more about that statistic, but I just grabbed it from their website last night, because what we know is if we can help guide a mother through her pregnancy with emotional and physical support, we can prevent a lot of the anxiety and the depression that then follows, either a healthy outcome or an unhealthy outcome. But some of the main tolls is productivity in the workplace. Moms don't want to go back to work. Dads, partners don't want to go back to work. It's extremely hard to leave the house when you're grieving in a culture that has, especially here in the United States, has removed death from the home and taken it to a funeral home. So there's a lot of cultural issues that play into the grieving process. We actually, the cost is more for mental health expenditures than it is for preterm birth and productivity loss. So we're looking at quite a few economic factors for why we should be talking about this more with families.
Yeah, absolutely. It's there. And I know that you talk about a rainbow pregnancy. So do tell us more. I know we're going to be going into detail, but overview that for us.
It just kind of came up about, it's really been within the past 6 to 7 years that I started hearing rainbow baby, rainbow pregnancy. And I was like, what is that? And I was like, oh, that was me. That was a pregnancy after a loss, a subsequent pregnancy after a fetal demise or a stillbirth or a neonatal loss. So it's hope. It's a signal of hope that life can go on and life can get better again.
And how many women do you find after loss continue with another pregnancy? So what is there statistics or information on that? The ones that actually go on to have another quote unquote replacement baby, which is terrible. I love the term rainbow, versus the ones that just go, no, I can't possibly risk doing that again.
It's significant. That is not a statistic I actually can pull out of the air, but
yes.
But we know that just in the United States alone, every 20 minutes a baby is stillborn. So
whoa,
yeah,
that's okay. That's huge.
Yeah. So no one's talking about it, and it's a very well kept secret.
Yeah, I do know. I think a lot of health professionals around the world or maternity health professionals around the world are aware that the US's stats are pretty horrific for a developed nation. But when you put it in those numbers, boy, oh boy, that's really high.
And that's more babies than SIDS and prematurity combined. So
wow.
So what we really have is a data problem. We have a data problem because we're all collecting death with different descriptions. And so we can't really compare apples to apples. And so we'll talk more about research in a little bit, but I'm a big proponent of research and advocacy and education for our providers. And I'm just
absolutely. So what are the main causes of perinatal loss?
There's 5 main causes: birth defects, preterm and low birth weight, maternal pregnancy complications such as placenta previa and HELP, abruption, a lot of uterine abruption, sudden infant death syndrome, which is the first 3 months of life, whether that's SIDS or just heard of a new one the past few years is floppy baby syndrome.
Right. And SIDS, of course, is what used to be referred to as cot's death. Same thing. Yeah.
Yeah, and then injuries such as car accidents or suffocations. So those are the 5 main reasons that we're
of
losing.
infant death.
Yeah.
Yeah. So, but where are we at with regards to, do we have stats on stillbirth rate? Are there? No.
They get dumped into different pots of numbers.
Right.
And so it's taken, so I work closely with the Star Legacy Foundation, and our main goal is to collect actual stillbirth numbers aside from all the other losses, so that we really know the scope and depth of this problem.
Yes, and also I imagine what would be so valuable is to know the maternal well-being, meaning is this a woman who had a very complicated medically, maybe she has a very complicated medical history, or maybe that was a complex obstetric pregnancy, or maybe none of those, you know?
Yeah, I mean,
so what you're saying is we don't know at the moment the stillbirth rates for healthy normal women of what was perceived to be a healthy normal pregnancy.
Correct.
Right. Wow.
Yeah. And I mean, I was
relevant.
There was no reason to expect that my third would have died from cord torsion. And now what I know 15 years later from reading about cord research is that we can look for defects and malfunctioning placentas, cords. We can measure volume, you know, but
we can, and we do, and I mean that should be these days, you know, part of anatomy scans, and of course, you know, scanning equipment has improved over the years, depending on how old the equipment is that a particular, you know, radiographer would be using. Okay, so tell us what is the standard of care?
Yeah, so there's been a lot of investigation by the perinatal and neonatal nursing publications about what is a bereavement program standard of care. And so here in the States, we have Resolve Through Sharing, which partners with a lot of our agencies to kind of develop what is this standard of care for bereavement. And so it's enhanced services for parents who experience a pregnancy loss or a perinatal death. The standards cover all pregnancy loss situations that women and parents may experience. And so basically what we're bringing in is a set of 6 criteria that hospitals and clinics and birthing centers should be following in order to give effective, consistent continuity of care across bereavement. And
so these are the guidelines that are being put into place, but how successfully are they getting?
It's not successful at all.
Yeah.
It's going to really, so if I had a magic wand, I would ask our insurance providers to compensate providers for following the standard, just like we do with mother baby, family-centered care, and the baby-friendly initiatives. If we had a bereavement initiative that actually gave continuity of care from county or city or country to state, I mean, we're seeing families reduced to tears because they didn't get a standard of care that the other family got in support.
Yeah. And you know, when I'm thinking about something as a comparison, you know, like the breast friendly initiatives, which various governments have ratified around the world, you know, and which hospitals are all expected to follow those policies of being a breast friendly hospital, and you know, that was led by the WHO. So gosh, you wonder if this, you know, I have to ask that question, is there any direction coming from the World Health Organization on maternal grieving of loss like this?
You know, I used to have that. I have it here in one of my
No,
dream
that's all right. I'm putting you on the spot there, but I think that there's been so much progress. You know, I mean, there could be loads more, but there has been a lot of progress in the last 20 years of women's issues coming, you know, getting more light shined onto them by the WHO. So that's probably where it might need to come from.
Yeah,
but we digress again. But so if we take it back down to those individuals, you know, how do families feel the impact of the perinatal death?
All right, you ready for this? Because it's not pretty. But parents are 3 times more likely to have negative psychological symptoms in the first 9 months of their baby's passing. 6 months later, parents operate at a 63% rate of normal productivity. So fog, cognitive fog, emotional irritability, inability to sleep, trouble communicating in social settings, a lot of dysregulation. 60 to 70% of grieving mothers report grief-related depression symptoms 1 year after the stillbirth. And half of these cases and symptoms lasted 4 years. 4 years after a baby passes. And it's estimated that 4.2 million women in the world are living with depression secondary to a stillbirth.
Right.
So I can just say for myself that I still am not over it. I will never be over it. You know, I will always be the proud mother of Helen Hensley. But I've had to raise my other children in the shadows of a rainbow, and it's of a loss with a rainbow, and it's staggering, the stigma. In group last night, I lead support group for families, and last night they were talking about friendships, and they were like, I lost all my friends, nobody wants to come hang out, nobody wants to have dinner, everybody's afraid to invite us places. And we did a show of hands, and there were 20 couples on this this nationwide Zoom. Mm-hmm. And every single one of them raised their hands for feeling isolated and that their friends had abandoned them.
Wow. And you know that those friends would have, probably the great majority of them, were just giving them space or thinking that they're giving them space, unsure what to say, how to say, what to do. And that's just so sad. So sad. I mean, there's obviously just so many unintended consequences of perinatal loss and maternal mental health, and that statistic that you just said, that 6 months later, parents are still operating at 63% of their normal productivity. That's massive.
And we're expected to go back to work in 3 days.
Yeah. And this was work that this is not like them returning to what they were planning to do. This is completely a change, because they were expecting to be home with the baby and not going to work. So going to work every day just reminds them of the fact that they are not, that they're able to go to work and that they're not at home looking after their baby.
Yeah, they don't get bereavement leave. They don't get maternity or paternal leave. They don't get life insurance or death insurance policies. They don't get, it's really hard to get family medical leave. I mean, what are we asking of our friends and our colleagues?
What about the impact of perinatal death on the community? How does that look?
It's pretty grim too. So the direct cost of a stillbirth, for stillbirth, are 10 to 70% higher than a live birth. So yeah.
Wow.
10 to
So
70%.
there is, okay. So financially, it makes huge sense economically for the health system to do a lot more, because it's actually going to save them money.
Yeah, it would save them a lot of money. So this is where we get into really sticky conversations about palliative care and termination. Allowing the body and the mother's body to parent as long as the body feels like it needs to parent, rather than going in and medically intervening and removing the baby, even if it starts past or if it's not intended to live long. What if we allowed her to parent in utero and properly grieve and prepare for this baby's passing, so that she can have a grieving process, have postpartum support, and start to grow her rainbow in a healthy way, rather than living with the stigma of a medically induced abortion? I
guess when it's I guess it becomes tricky if the baby has already passed, because she runs the risk of sepsis. So there's only, because basically for those watching who are not medical health professionals, to be gross, the woman has dead tissue inside her, and there's only so long that the body can tolerate that without her becoming potentially very unwell from this. And so but it's a different situation with
it is.
Potentially with a live baby that's not expected to live.
In my community, they're rushing. In my community, they're rushing it. They're saying,
and that's the point.
Baby has passed, and you have 48 hours to decide you have 48 hours to show up to the hospital for a D&E or a D&C. And I'm
48 hours. Oh yeah, no, that is rushing it. Okay. Okay. I mean, you shouldn't be doing a more common, first trimester miscarriage. Really should not be having a D&C within 48 hours. We should give the body longer to naturally expel, and the mind.
To absorb and react. I was able to carry Helen for 3 days prior to being induced, and it was a gift of time to carry her body and accept what had happened.
So what support services are there at the moment that can help?
So there are infant loss doulas, and they are kind of new to the scene, but I was trained by Cherokee Isles here in the States as the first infant loss doula in North America. And she really specialized in peer support certification. So as a loss doula, we have A, suffered a loss ourselves, and B, we are certified doulas who know how to navigate the medical system and help mitigate and make memories. Her tagline is maximize memories and minimize regrets. So our whole slogan is to slow down the process and help the parents bond, connect, parent, grieve, and breathe. Most doulas who are certified under an agency are going to have some training in bereavement and loss. It's just not going to be as specific as a loss doula. Integrated healthcare systems, care coordinators and nurse navigators with social workers and chaplains. And lastly, Postpartum Support International has trained army of therapists who specifically understand fertility, frustrations, reproductive challenges, and the mental health of the mother to help support a family through loss.
And do you know if the infant loss doulas that are getting trained in the US, are you aware if this similar training is occurring in other areas of the world?
I'm pretty sure it is. I haven't spoken to Cherokee in a couple of months, but it's definitely something that is a movement across the world to make sure that families are given a bundle and a support person and somebody who understands grief and loss and burial rights. I mean, I work with a lot of families in rural counties around where I live, and every county has a different law on whether you can bury your baby on your land. And so having those kind of resources saying, yeah, you can take your baby home from the hospital. You don't have to take it to the morgue and the funeral home. And you can take your baby home and rock it in their nursery and make memories. So these are just tips that are helpful for families.
I'm just curious, what's the how normal or abnormal is it that autopsies are done?
They have to be requested and paid for by the parents. So it's very expensive, and it's often a really hard decision to make because they're in fight, flight, or freeze. They're not able to really, and so having a loss doula or a midwife there with them to help them say, you know, this is what we're seeing on a it's called just a general autopsy. They don't actually the body, they just do an overall scope of the baby and the placenta, and that can give a lot of good information. Some families who've had multiple losses and infertility struggles will ask for a genetic panel, and it's quite helpful. This is where we're getting our research, is from the placentas of stillborn babies.
Yeah, and I guess that's probably one of those areas that parents wouldn't even be vaguely familiar with until they're in that situation, that and that an autopsy of their baby is not like, how can I say, an autopsy of the placenta will likely produce as good a results as an autopsy of the baby itself. And meaning that we don't need to chop in to your baby. If the histology's got that placenta, then a lot of things can be answered from that.
Very true.
Yeah. So, gosh, it's just so tough. And why do you think the grief is misunderstood, or just not even misunderstood, just not understood?
Yeah, it's nobody wants to talk about things that are unthinkable and out of natural occurrence with life. You're not supposed to bury your babies, and we're seeing generations skipped, and grandmothers and mothers are grieving the loss of their grandchildren. And so avoidance there's three reasons that Dr. Rando talks about perinatal loss that are really consistent, that families feel unheard, is they are often in avoidance. They're in disbelief and shock and that cognitive fog that we talked about. They then move into a phase of confrontation where they're trying to adjust to this new reality with the intense emotions and physical distress that they're going through. And then they move more into a phase of accommodation. So connecting with their baby and discovering who they are as parents. That would be memory making, maybe a funeral service or a burial ceremony, as well as shadow boxes and knitting. I was a smocker. I know that y'all know what smocking is. but I was an English smocker, and I ended up
I'm just going to put in there only because of the accent differences. Not smoking, smocking.
smocking. I made dresses, little dresses for my girls, and I did a needle and thread, and I would make these beautiful dresses for my daughters. And when Helen died, I started making burial gowns. And so that was how I accommodated my need to parent, my need to grieve. And I was actually doing a lot of therapeutic behaviors by counting stitches, balancing anxiety with sadness, crying with mathematical, measuring these stitches. And it was really a way of coming out of my grief by creating.
And you were creating or making these to give to other people?
I donated them to the local hospital. They had a whole closet filled with burial gowns and miscarriage buntings and baby heirloom blankets and matching bonnets. And they were, it was called Helen's Threads of Love. So for 10 years, I had a series of knitters and smockers and heirloom sewing, and we made sure that no baby went unclothed after a loss.
That's just beautiful. I know in the main hospital that I would associate with birth has a whole lot of little old ladies locally that do a whole lot of knitting, and of all different sizes, you know, for both live and passing babies. You know, because no beanie is tiny enough sometimes. That's beautiful what you were doing. Now, I know that it's funny that you make that comment, not funny, but it's that you make the comment about the right to that death has been taken away from the home. And in New Zealand, where I have been born and raised, our Indigenous people here are the Maori, and there's one thing I could say: they know how to do death.
Yes.
And yeah, there is an amazing. You know, I don't have any percentage of Maori in me, but I kind of from a passing point of view, I wish I did. And the way that I've witnessed how Maori deal with death versus the way that I've witnessed how Pakeha, which is the New Zealand word for European, it's so different. And so we, you know, I imagine that you've got the same thing going on in the US. That, you know, so tell us more about the non-Western, non-European ways that it's dealing with that differently.
Well, so I mean, there's every
you got
culture.
Your biracial people of color mothers. I know that's in there.
Yeah. So I mean, it's unthinkable how many mothers of color and non-white mothers are losing their babies and losing their lives because the standards of care include racial disparities, that they're more likely to have limited opportunities to better their health. They have an accumulated generational stress in their genes that has been passed down through trauma. There's an implicit bias with healthcare providers that people of color are substandard, and the access to healthcare for someone of color is tremendous. It's hard to get an appointment. There is lack of quality care, and just systematic racism here in the States. We are up a huge creek. And There is.
Yeah, we've certainly on these webinars had that topic come through quite a bit with American speakers. I'm wondering, do you know from within your specialty of perinatal death and processing that, is there similar things going on in Canada, or is it quite different?
I don't know.
Okay.
I wish it sounded like somebody was from Canada. I wish they could speak to that. I do know that we're extremely siloed. We're extremely siloed here in the States, and especially in my community where there's so much hurt, and that people are not talking to each other about the horrible things that we have done to our Indigenous people and our people of color. So I have partnered locally with an African American church that runs a perinatal program for mothers of color. And we are hosting a symposium conversation in a few weeks to really talk about healing. What do I, as a white Anglo-Saxon woman of privilege, what do I need to say to convey my sincerity and my appreciation and my love for my sisters? And what do we need to do for them to hear us and forgive us for being born into colonialism? And so how can we learn to work together to shift the need and save more babies and save more mothers? But until we have those conversations that are really uncomfortable, nothing's going to change.
Yeah, you probably hit the nail on the head there, that things can't change unless there's conversations. And I know that, you know, here in New Zealand, there's been loads of conversations over time, and I think that there's been a lot of healing that's gone on. Although in general terms, even though a lot of what the Europeans did initially in New Zealand is certainly not as bad as a lot of other countries. So we've had problems, but and that's not to say that, you know, yeah, you guys have got some big issues going on, and I think that was really just a case that by the time New Zealand got colonized, they'd already made a lot of mistakes in a lot of places, and it was a feeling of let's not repeat that, but some of them managed to do that anyway. Goodness me. But that's so talk to me more about why perinatal grief is more complex than normal grief.
Yeah,
it's a really important understanding of comparison, I think.
So normal grief differs from complicated or prolonged grief disorder in that normal bereavement is not persistent. It's not as intense. It's not as disabling or life-altering. It's not experienced as a severe threat by the bereaved individual. So we feel it like needles going into every orifice of our body, being ripped out and thrown out in front of a public for everyone to view. I was named and called a martyr for years because I always wanted to talk about my baby that died. I was always sad and living with regret that this horrible thing happened to me. And, you know, it's just not true. She's a beautiful light in our life, and we've made lemonade out of her loss. And other families will go on, but they don't need to do that in silos and so scared that their families can't remember a birthday or remember a death day or remember bereaved Mother's Day. It's, you know, it's just not all bed of roses.
Sorry, how can psychotherapy with a perinatal bereavement specialist help the families? And, you know, how do they access it, and what sort of, you know, what occurs in that process?
Yeah. So my goals in therapy is to help them with interventions that promote personal choice, that help support their decisions, whatever their decision was, and promote dignity and respect for the family. And so we do that through validation, just validating that this is real. She did experience this. He did experience it, and they deserve to be heard and seen. Responses, we teach them how to respond to grief and how to ask their family members for what they need. We teach a lot about boundaries and what are healthy communication methods for asking for what you need, and having exit strategies at family dinners. How do you get the heck out of there with grace? We talk about challenges to the traditional models of grief. Everybody's like, oh, there's 5, steps of grief, and you go through them. Well, it's not linear. It is a big jumbled mess of emotions, and you get blindsided by the lady at the checkout, at the grocery checkout, because she's huge and about to give birth. And we use a lot of theoretical conceptions about attachment, about how to attach to this baby, even though the baby is not there. So I teach my parents how to parent their deceased through creating rituals, through creating altars, through having memorial walks, and journaling, and being creative, planting, gardening. A lot of those are techniques that we integrate into the therapeutic sessions.
And talk to me about bonding with a subsequent pregnancy.
So psychologists Jennifer Buckle and Stephen Fleming are co-authors of Parenting After the Death of a Child, and it's a practitioner's guide of helping families survive a child's death. And there's this type of hypervigilance that parents get of hovering over a rainbow baby and other living children, as to not, we have sacrificed the ultimate loss, and I can't bear to lose another child. It would absolutely destroy me. So I'm going to hover and protect, and I'm not going to let them go anywhere, and I'm not going to let them talk to anybody. And it's not good attachment. It's enmeshment. It's not healthy. And so we work a lot on that. We also help them form and recover a relationship with the deceased. And so helping them pick up the pieces of this shattered glass, and helping the family put it back in order and find a way to function around the stigma, and not be named the martyr, but the survivor.
Yeah, and that integrative care, how does that sort of family-centered bereavement help with that rainbow pregnancy? I mean, I know exactly what you're talking about, because as midwives, when you're caseloading, you see it, that somebody has undergone a loss, and they become hypervigilant with that next pregnancy, which how can you not react in that way when you've been through that? But how do you find that it helps things?
Well, the integrative piece is mental health, behavioral health. Having, a social worker is great at connecting people and linking them with services, but a therapist is going to build a relationship with them over time. Because like we heard earlier, this isn't going to go away in 4 months. It's going to take 4 to 8 years. So wouldn't you rather have a colleague, a collaborator, a workshop to go to and say, I'm really struggling this time of year. I know it's because Helen died, and can you help me through November every year? I'm going to be back. And so that's the integration that we need to see more of, is all the clinical and community resources, but we need to make sure that mental health provider is also in there.
And the fact that the women need access to that, or their families. But when you do them, I understand, of course, hospitals, are all funded by money, and it's, money's what makes it go round. But when you see those numbers and the fact that it's more expensive at the end of the day not to treat than to treat, that's, it's like, and it could be compared to, the cost of having free breast screens, versus the cost of, not screening and having more women with breast cancer. And, it's, in a way, it's a no-brainer, isn't it? Because it's just an you could look at it from a hospital board point of view as purely an economically sensible decision. So frustrating.
Well, and the UK is doing it. I noticed one of our participants is in the UK. And so Dr. Alex Heasel is at Tommy's. And if you want to know anything in a gold standard about rainbow clinics, you just need to go to tommys.org, because they have mastered it, and they're doing a beautiful job, and they're saving babies, they're saving money, and they're saving lives, and they're keeping families intact with their mental health. So
that's an example of something that is working well in the community. And I mean, it can be compared in a way to, places that have lower rates of C-sections, because they've got better ways of encouraging normal birth, and economically it makes sense. And but there's a lot of other reasons it makes sense as well. So that's, what are some, are there any other examples of where it is working well in the community?
So let's see, where are we? So just child development, understanding where families are coming from, just with that hypervigilance. So
I guess you've got the Australian, they've got a bundle, don't they? I think
yes,
the
they have the
Safer
bundle.
Baby
Yes.
bundle.
Yeah, but where is that? I'm sorry, I'm looking for my notes. It's up here. Okay, so yes, the Australian Safer Baby bundle is designed to reduce the stillbirth. And so they're following some pretty good protocols as well for looking for fetal growth restrictions, as well as decreased fetal movement. So they're really following those gold standard protocols that we talked about a little bit at the beginning. But their statistics are amazing as well. In Scotland and Edinburgh, they're doing it. So, these things are popping up across the globe. And I have to say, I think it's because we had our stillbirth summit 10 years ago here in the States. And we brought in Jane Warland from Australia. We brought in lots of folks from New Zealand, and we're bringing in the Dr. Heasel from Tommy's, and we're looking at placentas, we're looking at data. And so I'm going to make sure that you all have the links to a lot of this research. And if you want a copy of my notes,
I'll just interject there. So for those who are watching live, and for those who have registered but will be watching this later, so anybody who's registered to attend this webinar will receive an automated message from Zoom in 24 hours time with some further information. But for those of you who are watching this months down the track, how would they, do you want to just go over, explain some of the resources that they could will be able to access it?
Yeah, so Postpartum Support International is the go-to when you see a mother struggling with her emotional health. There is a free hotline that will link you with providers in that person's country or area with who are specialized in all things postpartum. And these are special certified and trained therapists. So that's
brilliant.
That's your first go-to. And then as far as research, Star Legacy Foundation is doing a research project for the next couple of years with the University of Michigan, where we're actually collecting placenta data and medical records anonymously from healthy birth and from unhealthy births or unsatisfactory, compromised births, to really look at the data and look at the numbers. And so this is something that's been missing internationally for years, is a cohort of world births coming to one place and being analyzed and calculated together. So anyone who wants to participate in that, I will make sure that you have the link to that as well.
Fantastic. And tell us more about the Rainbow Clinics and what that is.
So Rainbow Clinics do a comprehensive review of history, as you were speaking to earlier, and they're going to look at what interventions may work best for the mother's conditions. They do a placental profile at 17 and 23 weeks and the anatomy scan at 20 weeks. The part that's beautiful about a Rainbow Clinic is that they're actually doing growth scans and Dopplers weekly, beginning at 26 weeks. And that's where we're getting a lot of the information. And that's that close monitoring of the fetal movement, whether it's hyper or hypo. Yes. We're looking at blood pressure. Is blood pressure hyper or hypo? And they're also getting mental health support. The anxiety in the third trimester quadruples if you've had a previous stillbirth.
Yeah, and even though the weekly clinics, like doing a weekly scan, is, for want of a better word, a bit of an overkill, if there are no medical complications, but the reassurance that it would be providing that woman is just, invaluable. That she knows that's happening. And of course they can do, for those unaware, they also do Dopplers on placental flow. So that's, a huge indicator of wellness, and other sort of biophysical profiling of that baby through the things that they're looking at, where the baby, it's a little bit like APGAR scores after a baby's born, and they get rated, so it's a little bit similar to that. They can be doing those things, which is so what do you find that the families themselves want, from those clinics? What are they after?
They want research. They want relief. They want to be heard. They want an answer. They don't want to just hear, oh, this happens. It happens in threes. We don't really know why the stillbirth happens. It was a perfect storm. Hello? Wait a minute. No, this was my child. This is my future. This is family. They want balance. They want to have some trust in their provider, that their provider listened to them. And so with the Rainbow Clinic, that's what's happening. They're building rapport, they're building trust with their provider. The provider's seeing things get better or get worse weekly, and they're going, you know what, it's time to act. It's time for an intervention. And what does that intervention need to be based on the mother's risk? And so could it be go home and call your midwife and try to get things going naturally as quickly as possible? And in 2 days, then we'll, if nothing's happened, we're going to try something different. But having a plan rather than waiting for a result.
And I'm thinking too, there's been such a trend in recent years of more VBAC clinics opening up prenatally, where there's a specialized midwife who's it goes through, and we could be doing exactly the same thing with the rainbow clinics,
Yes,
basically.
Yeah.
I just love it. So obviously I guess there's a motivation with VBAC clinics that there is, again, a huge financial saving for the hospitals if those women do have normal births versus cesarean births, though that's not an incentive for private obstetricians, unfortunately. But and the same thing really is occurring with the rainbow clinics, isn't it? That it could be, it's economically viable just because it's going to save some other consultations down, because that woman is, if she doesn't get access to something like that, she is going to be driving her midwife or her obstetrician a little crazy, because she'll be wanting, this whole, I'll see you in 3 weeks thing, doesn't go down so well.
She's going to be up at the labor and delivery unit going, can you check my baby? I don't feel good. And that's what we tell them. We're like, trust your intuition, trust your wise mind. If you feel something's off, go find out. I knew right away. I was in total denial for 3 days that her heart had stopped. But I could smell things differently. I did not feel good. I felt very off. There were a lot of red flags, and she had hyper movement right before she went still.
Did she? Which is a red flag.
Mm-hmm.
And so what can we do as birth practitioners and other maternity health providers to help families impacted by perinatal death?
Just reaching out to them and even saying, I don't know what to say, but I'm here with you. Sitting in the puddle with them, helping link them to services, and helping them find hope.
Yes. And feeling like, somebody's prepared to talk to them. Instead, as you say, of feeling like nobody knows what to say, so nobody says anything. What we need, we do need to come to a conclusion soon, but I've got some other questions I want to get through. What is important for families to know about parenting a rainbow baby?
Yeah. So Joanne O'Leary is amazing, and she's written many, many wonderful books about parenting a subsequent pregnancy. And the range of emotions, thoughts, and physical experience of bereaved parents is very wide. And so just being prepared to help them navigate that. Guiding the family to finding hope by learning to love, honor, and parent their deceased baby while they're growing another baby. A lot of times they feel guilty that I've left this one behind and now I've got this one. So there's this nice integration that we do during subsequent pregnancy support group that happens weekly, where we have a cohort of peers that's led by myself and Joanne, and we're actually grieving and growing at the same time.
Nice.
Supporting the rainbow pregnancy with prenatal visits. There's a checklist so that moms know exactly what to ask, know what to look for in their providers. Guiding the family in facing bereavement with anxiety and coping skills. So again, helping them anticipate all the wrong things and how to emotionally absorb that and not take it out on your partner or your children. We try to model how to build a healthy attachment with your new pregnancy, and that's that not becoming enmeshed and that hypervigilant behavior that bereaved parents tend to follow, and helping moms balance fear and hope and with movement and monitoring. They're usually very hypervigilant about how many kicks, did it kick, did it move, where is it not moving? So how do we help them navigate that to where what is a red flag and what is normal, because it's
And
going
then
to be
what can
different.
what can the parents do who are raising a rainbow baby?
Just make sure that, it's going to be complex and it's going to be anxiety provoking, but attending support groups, learning about attachment theory and positive parenting prevention really helps families face struggles that they may encounter. Triple P is actually a program that is called Positive Parenting Prevention, and I use that a lot with my families. The idea is that you're going to prevent the behaviors that you don't approve of or don't follow your family values, rather than trying to correct habits or behaviors that may be punitive and against your family values. And so these are some of the strategies that we use in therapy to make sure that families are growing healthy attachment styles with their children.
I just want to add in here. Look, I know that this, for those watching this video or live with us, I know that we are, over time for our normal 45 minutes that we try to keep to, but I want to keep going. So because this is just a subject that's so important and so not understood and so not spoken about. So I think we'll probably be another 10 minutes or so, but we're going to make we are making an executive decision here today that we're just going to go a little bit longer on this one. I don't want to cut this topic short. So what do you think is really the main takeaways for families who are facing a rainbow pregnancy?
Gathering up a care team, a support network.
Right.
Whether it's a social worker, a therapist, a priest, or religious counsel, somebody who can just be that listening ear for you, who's willing to stay the long haul, and but definitely finding a care team, a provider, a midwife, a doula, somebody who can just be that emotional and physical support when you need it.
And where can families call for immediate help if they're concerned about the mother's mental health? I mean, you see this where the partner particularly is going, who is where is my wife? Where's my partner? I've lost her.
Yeah. You kind of have, and you probably may not recognize your partner for a while. And this is true for men too, and fathers and partners. We are different people. We're genetic.
I'm sorry to interject, but the guys themselves, the level, they are fundamentally fixers, and give them a problem, they'll go and fix it. The rubbish bin lid is jammed. Right, I'll fix the rubbish bin lid. And they want to fix, and this is something they can't fix.
No.
And the level of helplessness of feeling like they just don't know what to do, not just for their wife screaming with their own, it must be just so phenomenal. I mean, men often get into that place during labor, and often during that, first month or so, particularly in the postpartum, and they just feel like this third wheel. But boy, that sensation for them must be so overwhelming.
It cripples marriages. And so this is why counseling is so vital to saving and keeping the family connected and to keeping the marriage strong, is that men do grieve so differently, and they grieve physically and they grieve in an isolated way. And so the rumor is that they start to actually grieve the loss after mom has gotten better or partner has gotten better. And so they hold it all in and wait for her to show back up and then they're like, okay, Jesus, now it's my turn. And
Right.
and
Traditionally men tend to, whereas women will want to vent and talk, and so they can talk more to vent more, to talk more to vent more, whereas men tend to go into their cave.
They do. They like to chop wood. They need to go hiking.
Yeah.
They need to make bread. So
Yeah.
that's what we do in counseling, is we give them lots of outlets. So Star Legacy also has a men's group for grieving fathers. They have a parenting after a loss group, support group for living children and the family. They even have a grandparents support group for bereaved grandparents. We have it in Spanish.
Wow.
we got the whole gamut covered in free support group.
That is fantastic. Look, we've had a lot of commentary here today, and I just, you and I have been convoing back and forth, so I just want to flick through some of this. And yeah, this is great. A perinatal psychologist. Oh, okay, this is interesting. So we've got a perinatal psychologist and retired NICU RN, and she's in private practice in California. His special interest is working with families experiencing challenging pregnancies, especially when the child is not expected to survive very long at all. Boy, you know, what an area to be working in. And we've got another person here that her role, she's come across women who have lost babies, had miscarriages. There's a lot of grief and sense of loss, which affects people not only at the time but also much later. Sometimes the manifestation of grief in physical conditions, as well as mental and emotional, is lifelong. And her role, she's a reflexologist. How interesting. Clients sometimes disclose their grief to me, however many emotions are conveyed through the feet, and the conversation can be started gently that way. Fascinating. Fascinating. Oh, we've got Jill here from Who's Shoes in the UK, and I know they are doing some really powerful work with some amazing people over there with neonatal palliative care. Fantastic there. What else have we got? Yeah, such an important homeopath here, just sort of saying it's just such an important topic, just worldwide. So just thanking you there for your wisdom. Extraordinary, another comment here, extraordinary when people who have had bad experiences go on to help others. Yeah, look, and I have to say, boy, you know, I've just seen this. I would say doing these interviews that easily more than 50% of people that are on these webinars would be in that category in some way.
You know, there's a researcher here in Chapel Hill at Dr. Tedeschi.
Oh, I've just had Catherine freeze. I'm not sure if there's an issue at my end or her end. I'll just carry on reading these. It's extraordinary when people have had bad experience and go on to help. Absolutely. Will the statistics be made available for reference? So with regards to that, there are some links that Katherine is going to, will be putting together for those who are registered to attend, and you'll receive some links, and some of that information may be there. Oh, we have completely lost Katherine now. Okay, she might try and dial in, maybe something going on with her internet. But for those of you who are watching this information later, so there, you know, you will be able to Google Katherine and find her in internationally. Thank you, Katherine. What else we got here? Someone else is commenting, I can tell you as a clinical reflexologist, these symptoms last so much longer than 6 months or 4 years. It is profoundly significant many years later. Oh, absolutely. I mean, as Katherine said herself, you never lose it. But I guess oh, she's got it coming back in. Oh, we're back. Yay. I've just been reading through some of these last comments. But yeah, and somebody was saying that she's, in her clinical experience, she's found that the symptoms lasting a lot longer than 6 months or 4 years. Absolutely, it's something you never get over. But I think that what you're talking about particularly is those averages of people being able to function again, to their capacity, a changed capacity, but feel like they are able to get on a bit more, and some never do. Someone else here saying, yes, parenting in utero is my passion. Helping parents to be the best parents they can be for however long they are able to do so. It gives parents that autonomy they deserve. Another comment here, in the UK, we have increasingly good neonatal bereavement care, some wonderful work around memory making, sibling support, and more. So that's what you've been talking about, that the UK is really doing a good job. And so, here we go. We got a comment from Canada. So here in Canada, we are building and growing and improving all the time in this area, but still much work to do. And a comment here saying that is so beautiful, Katherine, what you have been doing. You are very brave, and I respect your interest in research and trying to change how loss of a baby is approached in a much more sensitive way. And somebody agreeing here must be a Kiwi. Totally agree, Carrie. We regarding Maori death rituals. Absolutely, boy, it's just stunning ceremonies and just ways of coping. So much to learn from Maori communities. Love the genuine conversation and listening to you. In New Zealand, oh, wonderful. This is where, we are very much an international organisation, but my Kiwiana can't help but come in. Can you please give the name of the Rainbow Clinic again? Please. Oh, and we had, while we lost you there, we had queries about how people can get in contact with you. So because there is going to be people watching the webinar that were not registered for the webinar, so we'll definitely get you to go over that just before we sign off. Got another comment here. Alex Mancini, Paula Abraham, Nadia Leek are also wonderful people being followed in the UK who are working in these areas. Some more thank yous coming in, and I think we've sort of got through them all. So very active commentary coming through there. And so look, can we wind up with Katherine, anything that you would like to add in that you feel that we've missed, and also those contact information that for those that were not registered to attend?
Right. So I am an open book and I love collaboration. So please, I would love to have a conversation. Let's have tea over Zoom, especially for those out there who are doing this work and would like just some fresh ideas. I've been doing palliative care for about 10 years now. And so it's just, please don't be shy. I'm a busy gal, but I always make time for my fellow comrades around the world to
thank you. And maybe just you could go over your email address.
Sure. It's my full name, and I'm going to spell it out for you. It's nice and long. Katherine, KATHERINE at Katherine, KATHERINE Hyde, HYDE, Hensley, HENSLEY. And so that's also my website, KatherineHydeHensley.com. And
Great.
please reach
So just
out.
Katherine at KatherineHydeHensley.com, and do reach out. So fantastic. You know, it is a while ago that I trained as a midwife, but thinking back on it, I cannot recall any specific practical kind of information or guest speakers or anything that we had to do with grief. There was such a focus on understanding the process of pregnancy, labor and birth and breastfeeding, which obviously there has to be. But yeah, when I think about it, it was definitely a skimmed over topic. And along with the topic of which became one of my personal things, was why babies cry. And just, you know, if a midwife understands the difference between a hungry cry and a tired cry and an overtired cry and an unwell cry, you know, then they can teach their mums. But if we're not taught, we can't teach it. And you know, the same thing with the process of grief. We are taught a lot about, you know, managing helping those women with live babies. We're really not taught a lot about helping the woman with dead babies. And yeah, I think the work that you're doing is just so groundbreaking and so important. And it's fabulous to have had you on here today.
Thank you for having me. I have thoroughly enjoyed this and would love to do more if more topics come up. That yeah, just to your quick point, is in medical school they get about 2 hours of bereavement training.
And we're not talking, we're talking about bereavement in general or maternity bereavement?
Bereavement in general.
Wow.
So I work closely with my education center here in town, and I train residents on perinatal loss.
That is really scary, isn't it? That's really scary, really sad. Yeah. Okay. Yeah, I think I hope that you know, by the time our grandbabies have babies, I'm not going to say by the time my babies have babies. I think that's too close around the corner. But by the time my grandbabies have babies, this hopefully will be just such a standardized part of how people are cared for. You know, because we still have to pat ourselves on the back as to the progress that it has been made and is being made. I'll close with sorry, before we close, is there anything else you would like to add? Well, I'm going to add a story, because this is not something that it's something that I didn't even learn about till my 20s and 40s. When I was 20, I discovered that I was a rainbow baby. Yeah, and my mother had given birth to a full-term stillbirth, and I'd known nothing about her. All I knew was there was quite a gap of time between my older two siblings and me, and that was because there was another baby in between. So that's interesting. But I in my 40s, late 40s it would have been. In my late 40s, maybe early 50s, something around there. And we, myself and my husband and our kids, all went to the town, city, with my mother, where I was born and where she kind of grew up a lot, because I wanted her to pass on the history that I couldn't remember and I didn't know. And one of the things that came up was, I said to Mum, oh my gosh, like, I know where your grandparents are buried, where her parents, my grandparents, are buried in this town, but where's my brother buried? And Mum said, I have no idea. Just as a midwife, I was just like, how is that possible? Like, I said, you need to explain this. Like, what do you mean you don't know? And she said back then, because losing babies was more common.
Yes.
So we are talking about, the 50s and 60s. It was more common, and everybody. She would say that everybody knew somebody who lost a baby.
Yeah.
But back then it was seen as the kindest thing to do for the woman was they didn't see the baby, they didn't get to hold the baby,
Yeah.
right? But the baby would be given, the baby would be put in a morgue, and then the local funeral director would come to the morgue and take the baby and deal with it. So the family didn't have to deal with it, and the mother didn't have to. But do you know what actually happened? I couldn't believe it. That baby, and this was normal, would get put into a casket of somebody else and buried. So, and the weird thing about that is that there's so many weird things about that, but is that the family who would receive that baby into the casket of their adult dead relative didn't know either. So all those babies are buried in other people's caskets with no headstones and and nobody knows. There was no records.
Talk about complex grief.
Yeah.
Complex grief, not being able to process the loss.
Well, and but the funny thing is, my mother doesn't hold that against anybody because
it was culturally okay.
It was the done thing, and and in a way, I think she handled the loss better than the average perhaps these days, because as she would remind me, everybody knew somebody that lost a baby.
Yeah.
So that's the harder thing these days, in a way, is that it's so rare in the Western world. Well, it's not rare because of your statistics, but I certainly don't. We're not surrounded by it in the same way as they were in the 50s and 60s.
Yeah.
Anyway, look, we've gone so over time. Longest webinar we've ever held. But very important topic, and thank you so much, Katherine, for your time, and for those I'm impressed with those that are still hanging in here, because
if anybody wants
way over time.
If anybody wants my talking notes or my statistics, I'm happy to share them with them. So reach out to me by email. And
yes, and that's where you can get some of those statistics, because I know that Katherine has documented some specific notes she's gone over today, so you could email her, and thank you for offering to send them a copy of that, because all those statistics and things that you've talked about were on your reference notes for talking today. So brilliant. Thank you. Mwah! Thank you, and bye to everybody, and a unusual beautiful, important topic that we have given some fantastic attention to today. So thank you, and thank you for what you're doing.
Thank you.
To help women around the world. Bye, everybody.
Bye-bye.